Well, thank you very much. First of all, congratulations for this 25th anniversary. But after your presentation, nothing is left in this meeting. So I'm going to, I'm going to move into a different direction, which I think is justified, and that is Imagenomics, Heart to the Brain. What went on in the last 3 years on a program that we have, which is very much dedicated to understand health before disease takes place. It's an age-dependent program, and certainly we are involved with actually very new technology. So let me just move into, let me see how it works. Which one?
Let's see.
No, it's not.
The slides are not moving.
I hope it does.
I hope it moves. Hold on. No, they're not really moving. Okay.
Well, let's try and see.
Try again.
This is not good.
Okay, it's working.
Let's try. Thanks very much. So we have, this is the program that we have, is Development and Innovation, Cardiovascular Health, Age-Dependent New Technology. And if you go to the bottom, this is what we have done over the years to understand the disease before or after the acute coronary events. But we are moving up now to understand how the disease begins. That's number one. Number two, different ages are different aspects that are related to the development or the prevention of disease. It's completely different at age 60 to 100, 20 to 60, or from birth to age 20. And on the right is, we are talking about new technology. We are not talking about charitable work, which is socially oriented. We are talking about imagenomics, artificial intelligence, innovation therapeutics, as we will talk today, and then the issue of single cell, like a macrophage, which can provide a lot of information about us. So having said this, let me begin, Let me begin now with people at between age 20 and age 65. What is the challenge? The challenge is, I am developing the disease or I am not? These are the conventional risk factors that are affecting the endothelium of the vessel wall with the entry of cholesterol. And here it is, how to understand a healthy vessel. Certainly you cannot go into intravascular imaging because these are already patients with significant disease that has evolved. So what we have done over the last 10 years is to develop specifically 3D ultrasound to address two carotid arteries, the main aorta and the two iliofemoral regions. And then we have used actually CT for calcification of the coronary arteries as an indirect technology to address altogether 6 different regions. And as I presented here last year, the first thing we learned is that the disease begins in the femoral region. No clinical events, no claudication, the arteries are very large. This is why the manifestation clinically may be in the small arteries, like the coronary arteries, but not where the disease actually begins, in actually most of the people. And this is based on 4,000 people that we have done such imaging technology between age 40 and age 55. Now, the question is, we learned something very fascinating. All of this was at autopsy, but I'm presenting now imaging in vivo. So here on the left are males, on the right are females. And here you have, under the age of 50, 2/3 of males have already subclinical disease, which is where we are focusing our research. One region being involved, 2 or 3, 4, 5, or 6 in women, half of them have already subclinical disease by the technologies I mentioned under the age of 50. But there is more. We are following these people for 20 years now, and we follow them every 4 years. And just on the first look after the baseline, 4 years later, 41%, there was some progression of the disease in one artery or another, in one plaque or another. I think this is very important. What we have done is MRI and PET of the large arteries in 900 people. And here on the right, you have you have PET, which really is the combination of cholesterol deposition and macrophage infiltration. And here on the right is magnetic resonance imaging of arteries that are actually already fibrotic. It's like a healing, and actually there is also calcification. And the key point I want to make is somebody mentioned platelets. I began working with platelets, and cardiologists didn't know what I was talking about. I'm talking 45 years ago. And actually, I had to deal with all the meetings with the hematologists. I was not in cardiology meetings. I will tell you today that the key issue in the defense mechanisms in health is the bone marrow. We are going back to the hematologists in a way. Let me explain to you what is happening. Now, when there is infiltration of cholesterol, the fat is found at autopsy. The bone marrow reacts, and actually the macrophages try to take the cholesterol out. And in general, is a winner. Here you have, defense mechanisms in yellow. There are some good, some bad. This one is yellow. But the first one is very good, and that is these lesions convert into fibrotic lesions seen at MRI. This is very nice, but let me tell you the patients you are dealing with. Basically, when the substrate is significant, a lot of cholesterol in the artery, the macrophages commit suicide. They think they cannot do the job, they become apoptotic, and they release cytokines, tissue factor, and metalloproteinases that may lead to plaque rupture. So what I'm saying to you, the patients that you see with interventional people, you are dealing a lot with a loss of a war in which the macrophage gave up, and it's a tremendous release of substances that can be very tricky. It's the same that COVID-19. In that case, it's not cholesterol, foreign body, it's the virus. And it depends the load of the virus, whether the macrophages are going to win or to lose. If they lose, they release all the substances that make patients to go into the intensive care units. The same happens in the coronary arteries. So we have a defense mechanism when the substrate is not too large, but when in fact the risk factors continue, the ones I mentioned at the beginning, and the cholesterol keeps entering, we are in defense mechanism number 2, which is basically a loser. I look at my presentation last year here. And actually, I don't know if the title was the same, but I will tell you 2/3 of the slides presenting today are different. And this was published 3 weeks ago. And basically, is when we do PET, we can see the bone marrow, how it is activated. You see this here. And actually, you see in the next slide, this is actually what we see with positron emission tomography. So we have a complete parallelism between activation of the bone marrow and deposition of cholesterol in the vessel wall, and this interaction between cholesterol and actually the macrophages. So one of the first concepts that I think is important is that the cardiovascular disease, atherosclerotic disease, obviously is a silent disease. The iliofemoral region is the first one that is sensitized to the development. And then we have the protagonists, which are the risk factors, and then a war between the substrate, which is the deposition of cholesterol with the risk factors, and the issue of inflammation. And we already talked about winners and losers. Here comes an important second concept, very important actually. Here are the 4,000 people that we studied at middle age, high Framingham score, middle and low. You know the colors means disease subclinical. Why we have so many people who actually within just one risk factor or none, they already have significant subclinical disease? This is a critical question. LP little a, fibrinogen, my friends, there is something else in all of this. And this is what I want to show to you. Number one, fascinating. The guidelines, which are completely primitive, I have to say, on the guidelines on prevention, the guidelines are all based on clinical events after age of 40. If you go below age of 40, you don't find anything that is meaningful. It's forgotten. And it's only with events. So what happens is if you go to subclinical disease, you realize that a normal LDL cholesterol means a lot of subclinical disease. You have it here. a cholesterol LDL of 100 to 120. That's what's considered normal. But look at this. You need to have an LDL of less than 70 to talk about normality without subclinical disease when all the other confounders and risk factors are taken into account. Number two, hemoglobin A1c. You just had a presentation. Hemoglobin A1c, when it is pre-diabetes, may lead to events. Sure, we have the data. It's exactly the same data. We just published this. A hemoglobin A1c from 5.7 to 6, which is pre-diabetes, has a lot of subclinical disease already. So to say that hemoglobin A1c is an alarm that you are going to develop diabetes, I say it's more than an alarm. You're already developing the disease. So what we consider normal today is completely abnormal because we all have been focused in heart events in age of 40. The same happens with triglycerides. So this is the number one concept that is important. What we consider normal is not. And the second is equally important or perhaps more. We got into the cardiac study, people between age 20 and age 40 that were followed for 40 years. And what we look is the impact of the risk factors in the first 40 years of life. Cholesterol goes up and down, blood pressure goes up and down, and you have an area in the abscissa, is the time of follow-up. In the ordinate, what is the level of LDL? And that area is telling you the impact. Well, we found something fascinating. It's just summarized here. And again, part is published. LDL cholesterol, the fluctuations within the first 40 years of life have a huge impact. The area that we are measuring, and this is the blue, into the events that happen later in life. And that is, higher are this area before age 40 has much more impact than the Framingham risk factors that we look at age 40. This is a complete change in our understanding of this disease. We are missing everything. We only act when the disease is advanced, and we miss decades of the problem, as I am presenting here. So the second concept that is critical is cardiovascular disease, atherothrombotic disease, is very frequent without obvious risk factors. First, we consider normal, which is quite abnormal, so clinical disease is there. And second, there is an age cumulative effect that has been completely ignored. And these issues are critical because what we are doing is absolutely measuring subclinical disease and we are measuring events. So I think this second concept is also important. This led us to the third one. We are developing a trial, the first one in young people. People between age 20 to 40 with an LDL cholesterol more than 70, which we consider is abnormal, are going to be randomized into bringing LDL to 40 to 50 versus what the guidelines say. They say at this age, please take care of the risk factors. That's what all the guidelines are saying. Nothing absolutely specific. And the primary endpoint is the progression of disease. These are young people. The secondary endpoint are events, are young people, so you don't have many events, except I have to make a comment. We already have data in people between age 60 and 100, 12 years of follow-up. Can you see what is here? This is at time zero. Actually, we look at the burden of disease, subclinical, and these are older people, so we can look at events. And higher is the burden of disease, subclinically speaking, higher is actually the mortality. We just look at the carotid arteries. We now have the data in coronary calcification. So in our study, the secondary endpoint that will be events are very young people, but we will transfer the data of how much disease or burden of disease into what the burden of disease would give if this patient was older. And this can be done statistically. So that's number three. Number three is early in life, there is a unique approach, which is be strict into what is considered normal and abnormal, and this is the trial I just mentioned. Well, this is the story. The patient comes tomorrow, and you see somebody who you want to intervene, but by chance you have the brother or sister over there, and the question is what we should do. Well, let me tell you how we have done 7 projects now. Half of them are already published, which is 2 approaches to change lifestyle on people that we identify subclinical disease, something very pragmatic. One approach is individual. This is Kenya. where people have high blood pressure. These are the investigators. And I think I want to make one point. Individual approach, in this case, high blood pressure, because this is a poor part of Kenya, that they keep the food with salt. There's no freezers. They have hypertension, and we get with there individually. Pamphlets, phone calls, nurses, medications, and so forth. I can tell you one thing, very expensive. The individual approach to risk factor modification today, everybody talks about it. And your patient who comes to your office, who knows you, will follow you. But if you go globally, forget it. It's extremely, extremely expensive. This is a second approach. And this is the one, group therapy. We did this in the island of Grenada, in a town in Spain, and then in all these villages in Spain. And actually, I give you the total result of all these studies. The group therapy, all was randomized. One group, they met every month, 10 people. I am obese, you smoke, I will help you, And then they meet every month, 10 people with all the risk factors that you can send. Well, then this is randomized with a group that is individual approach. And just say, do whatever you want. Okay, and this is the control group. And I'm just summarizing all the studies that we have done on individual and on group therapy approach, because the results are very similar. One is more expensive than the other. Here is the intervention. Everything goes great. Cholesterol drops. Everything goes fantastic. Afterwards, something happened. It is a drop. Sustainability, forget it. We are not sustainable, all of us. We are not. We can change anything you want. After 2 years, you go back to where you were before. That's number one. So you have to reintervene. In our hypothesis, the reintervention will be, in a way, exponentially of benefit if you have intervened before. Okay, that's very important, and I have data on that. And the second issue is, what about the control group? Look at this. These are people that were controls. Why they did so well? Because of the culture of the place where they were controls, but other friends were intervened. So they learn about it, and they take care. So a control group that is close to the intervened group is fantastic. You have good results, much more than what you could expect. The issue of culture in an environment is the second aspect that we learn. So sustainability has to be repeated, and then the issue of the culture. So this fourth point is cardiovascular disease and risk factors. You can tell anything you want individually, you can do as a group therapy, but it's transient. So we have to keep in mind very clearly that reintervention is critical when we talk about risk factor profile. If you want to not become a neurotic and say, I am going to succeed. And what we have some information suggesting now, this is in children too. We have information suggesting that when you reintervene, the results are magnified exponentially. So that's the point. And the final thing is, what about genetics? Fascinating. What is more important in this disease, the genetics or the acquired risk factors, as I mentioned? Well, here you have the study that we did together with the 55,000 people, the ARIC study, the Malmö study in Sweden. This is our study, bioimaging, people between age 60 and 100. And this is the women's study in Boston, health study. And we took 50 genes. And the question is, how many mutations are? These are genes that in the literature appear to be important in coronary disease. This is a large number of mutations, middle and low, and this was related to progression of disease and events. The same happened with the 7 risk factors that are conventional. More risk factors, 4, 5, or 6, more events. What was very fascinating, there was no relationship between the genetics and the acquired risk factors, except in diabetes type 1 and in familial hypercholesterolemia. Now there is something else, though. Most of the people who have a high genetic risk have also a risk factor that may be modified. And we have a subsequent paper a year later, in which actually is when we drop in people with hypercholesterolemia and a high risk factor genetic profile, when we drop the cholesterol down, was a significant reduction in progression and in cardiovascular events. So there is no excuse to say genetically speaking, I am in trouble. I will add something else, though. When we talk about genetics, we are very superficial. Because what we found that 50% of the people who have parents or brothers or sisters with the same disease, in fact, the same acquired risk factors that the individual we are seeing. My father had a heart attack at age 40. Was your father a heavy smoker like you? Oh, sure. Is this genetics? So we have to be very careful when we take a history in categorizing people about genetic disease. Be sure you control or you go over the risk factors. But there's something else that came from the study, and this is the so-called chip. We go back to the hematologist. The bone marrow is a defense mechanism, but the genes appear to affect these macrophages that leave the bone marrow. For example, of the 50 genes, TT2, if it is mutated, is big trouble. And this is called chip. That is, the macrophages are genetically altered. And here it is. Let me tell you about the Cantos study. Very simple. As the macrophage goes along an area that is somewhat suspicious, previous heart attack in a coronary artery, there is a call there. The person making the call is the macrophage that circulates and releases interleukin-1. You know what happened? It's devastating. This is a defense mechanism that tends to really clean the whole artery. And in general, the cleaning is too much, and you can provoke rupture, and you can get too much. You try to get these debris out with the interleukin-1, making these macrophages from the bone marrow to be aggressive, and it's too much. That's the success of Cantos. You block interleukin-1. But there's something else. You know TT2? TT2, the gene I mentioned, is preventing this cleaning to be too far. So if TT2 is mutated, you are in trouble too. So today, two approaches is, can we interfere with the color, interleukin-1, this is Cantos, or can we edit in the future TT2 that is mutated? I'm just giving you the sense of what is the research going on at the present time. Well, here you have, in the bottom, something very important, and that is, in the defense mechanism, you have a very good news with early fibrosis if the lipid cholesterol deposition is not significant and the risk factors are taken care of. This is one in green. Two bad news. The disease progresses, and then the macrophage gives up, and everything released, tissue factors, metalloproteins, cytokines, plaque rupture, and thrombosis. The defense mechanism failed because the macrophages actually commit suicide. And number three is the last one I mentioned. The macrophage may be good, but genetically it's not. So the motor engine is playing. And this appears to be a key risk factor in the elderly population. And that is the defense mechanism comes out, but is not appropriate, doesn't have the quality on that. So here is an issue that this paper that, again, we published 2 or 3 weeks ago has actually an editorial comment which is quite interesting. Basically it says the marrow is evil. It can be defending you or can be betraying you. And that to me is a lot to learn about the future of pharmacology in this regard. And so this is basically what I'm saying. Cardiovascular events, the macrophages may become apoptotic if this is a problem or the genes are actually altering the motor engine I am mentioning. And now I'm going to finish by saying to you that actually we talk about the risk factor profile between age 20 to 60. But what is the challenge between age 60 and 100? Your brain, the cognitive function. And actually Alzheimer's said long time ago, more than a century ago, my disease is a disease of the blood vessels of the brain. It was a pathologist. And the question is why the research has failed, because it has been focused completely on the neuron, not on the vascularity. Well, I want to show you some data. And this is a study that we have done in 300 individuals in which we look at brain function, new imaging of the brain, imaging of the large arteries, and let me tell you what we learned. First of all, you see the risk factors, as you know, can cause large vessel disease. I have discussed this. But then hypertension, hyperlipidemia, and high cholesterol leads to a cerebral hypoperfusion, which we measure with MRI technology. This is all new. We can measure flow in the brain. Not only that, the entry of glucose by PET is decreased. This is number 3. And number 4 leads to cognitive dysfunction. And in Alzheimer's, we believe this also can operate. Alzheimer's may be a disease of the neurons, but the vasculature may be an accelerator. And in Alzheimer's, in an animal model, we have found also amyloid beta is prothrombotic, and we see the clots in the arteries, which we can actually prevent, in this case, with the use of Pradaxa. I don't want to go into more details. Well, this study was not the right study because not everybody went through the 5 stages. Now the study that we have, everybody goes to one stage after the other over a 20-year period. But there's something else in the bottom. You see this here? These are new markers like troponin. For the first time, and this is this year, we have markers of brain injury, NFL, GFR, that can tell if something goes on with the brain, like troponins tell us if something goes on with the heart. This is fascinating. So we are now measuring not only the amyloid situation in the circulation, the measurement of tau or the measure of beta amyloid, but also the measurement of these markers to see when things are beginning that may be actually problematic. And this leads to the final comment. Everything I mentioned to you about Imagenomics, new therapies that may come in the future by enhancing the risk factors, and goes into education. And this is what we do in children. We are dealing with 50,000 children around the world with randomized studies. That is, how can we prevent these children when they are adults not to follow the rules as we have not. And these kids with very small number of centers in the brain, they capture what you tell them between age 3, 4, and age 8. And this comes out when you are an adult. That's the projects that we are now developing, which I'm not presenting today. Summary. Later we are, my friends, this is where you are. Higher is the cost and less is the benefit. Earlier you go, higher is the benefit, lower is the cost. So I thought this presentation today, I presented to you 10 new concepts. 5 related to imagenomics in middle age, and 5 what's happening to the brain. Well, it's the fact of the matter is this is so exciting, and this I'm sure is important to you for one reason. When you see a patient that you're intervening, get obsessed about the risk factors of such patient. Because if you don't treat that, you are actually, I don't think the job is actually well done. Thank you very much for your attention.